I don't know how many have heard of pill parties. This is something I've seen locally where we have, especially in some of the very nice, the affluent high schools, kids will show up at a party and each person will bring 2 pills. And these pills usually are just taken from the parent's medicine cabinet, because what parent would notice 2 pills missing? Probably most would not. They come to the party and they put their pills in a basket and everyone kind of mixes it up and passes it around. And this makes for a very easy party because there's no cleanup of beer bottles, there's no smell of marijuana or smoke or anything in the house. And this brings me to the point of how dangerous, one of the real dangers of pills. It's not just the overdosing on the pharmaceuticals, which is high risk, but it's the mixing of pharmaceuticals either with different types or mixing it with alcohol or other drugs like marijuana that's particularly dangerous. And I think that is where we see probably one of our biggest causes of death from prescription drugs.
Doctor, do the kids even know what they're taking at these parties?
No, at these parties they don't. That's the scary part. They don't know what they're taking, unless they've somehow memorized the barcode on these pills, which most of the time those barcodes can be very different. So it's very scary. What we've come to is finally in a point in Florida where poisonings has become the #1 unintentional injury cause of death. This is from some of my own data I've collected. What we've seen over the past decade here, I don't know how well you can see the slide, but you can see oxycodone purchases, meaning purchases by pharmacies and hospitals to be prescribed, has jumped from 2 million grams to 16 million grams. I mean, that's a huge increase, well surpassing other prescription drugs. And along with this increase, we've seen a tremendous increase in emergency room hospitalizations for opioid use, and emergency room visits and hospitalizations for opioid use, increasing 300% in the past decade for hospitalizations and 50% for emergency room visits. If I were to superimpose this on each other, it is not a coincidence that the increasing prescriptions have led to, most importantly, not just visits and hospitalizations, but deaths. And the biggest concern is, our deaths have increased 500%, and oxycodone in particular it seems to be the big player. And on the next slide, you see oxycodone has the highest mortality rate of any of the drugs. Additionally alarming is that adolescents and young adults make up a big portion of the users. And even more concerning, as you'll see on the next slide, is we have seen a 700% increase since 2003 to 2010 in the number of newborns born in drug withdrawal. I mean, that's very alarming. In our area, I know we've had to basically open up units, neonatal units, just to treat kids in drug withdrawal. I mean, so you're seeing in Florida, almost 1,400 babies born with drug withdrawal. That is just to show you how epidemic this is.
And we used to think about crack babies, but now we have oxy babies.
Yeah, I've never heard that term like that, but I think you're exactly right. So, actually, I'll just tell a quick story. One of the things, when I started to notice this was a problem, was maybe about 6 or 7 years ago, when speaking of babies, I can remember seeing a 14-month-old girl come in to the emergency room, and she was getting to a point where she couldn't breathe. And our initial thought was, well, maybe this is an allergic reaction, or she swallowed something that blocked her throat. And come to turn out, and I had to send the family back to comb their house, the uncle of the baby had come and left a pill on the floor, which, like any child will do, picked it up, thought it was a piece of candy, and it turned out to be methadone. And she basically overdosed on methadone. We had to put her on life support, ventilator. She ended up doing fine, but that was the first point that really hit me. Wow, this is not just people with chronic pain getting affected by it, but it's a lot of innocent people along the way getting affected by it. So to me, what the question I started to ask is, how do we get to this point that 7 people a day are dying? What did we do? What's going on in the community? And here are just some things. I don't know if we know the answer, but maybe there's monetary gain. Perhaps some of these pill mills have played a big role in heavy prescribing. There's been probably some poor oversight and maybe some unnecessarily strong pharmaceutical industry influence. I've noticed the public expectation has changed with as much as people feel like they're allowed to or can tolerate pain. People less and less feel like they should be able to take pain because there are pills to help with that. Physicians have become irresponsible, perhaps with the prescribing. We have a disjointed healthcare system where it makes it hard for doctors to tell who's doctor shopping or not. And additionally, there's a group called the Joint Commission, which accredits hospitals. Or a private group. They had set standards, I believe, inappropriately for creating these pain scales, and as a result, strongly not just encouraging and incentivizing, but punishing hospitals and doctors that don't treat pain aggressively. And then recently, there was this Institute of Medicine report. I don't know if it's familiar with Institute of Medicine, but they usually put out good scientific information. Well, they put out this study, and in the first executive summary, they say 116 million Americans suffer from chronic pain. I mean, how does a country where we prescribe 95% of the world's narcotics, how do we have a problem treating pain? And so right off the bat, I just feel like we have allowed these publications and things like that to kind of dictate what's gone on in medicine. And if anyone hasn't seen this documentary, it's at the lower corner, the OxyContin Express, I recommend it. I had all my faculty, all the other emergency physicians I work with, watch it. And many of the senior level people, they really looked at me and said, what have we done? Always as a doctor, I feel like the one thing I could do is treat pain and suffering, but maybe we've gone a little bit too far, because as doctors, we want to believe our patients. So if someone comes in with a screw in their leg, from previous surgery, and they tell me it's hurting, I want to believe them. So one thing that's really made a difference is this prescription drug monitoring program. It allows us to actually objectively look and decide if people are really doctor shopping, or if they really have an acute pain issue. So I think that's helped. I think it really has taken a community to respond to this. So, for example, locally here, actually in this very same room I'm sitting in, several of the ERs, I think 14 or 15 ERs in Orlando got together, and we made national news because we instituted a joint chronic pain management policies for emergency rooms, where we would stop just giving out pain medications, for chronic pain. Now, there's a lot of drawbacks to that, but I think it starts the conversation. Pharmacists have been very involved with checking people's licenses, making sure there's no mistake on their birth date and stuff, so that we know who's filling prescriptions is who they say they are. Law enforcement's played a big role. Regulations have helped. Media attention's helped, and as well the chemical dependency treatment options has also helped.
Is there any work with the hospitals to do anything with, if they're being graded on your pain and suffering, how do we deal with that?
I think hospitals have just accepted that we're going to take that hit to some degree, and it's probably adversely affected some of things like customer service scores, especially in our area where prescription drugs have been a big trend. But I think the hospital said, what they said is, fine, we'll take that hit, but if it's for the benefit of the community, if we can save, if 7 people a day are dying from this, if we can make a difference, it's probably worth it in the short term to take that hit. That's a good question. And so here's what we've seen. The good news is we've seen a drop in the number of opioid poisoning, and the next slide shows a drop in the number of oxycodone poisonings. And for the first time in almost a decade, the number of deaths from prescription drugs has finally started to go down. You can see we're still nowhere near where we were prior to 2003, but I think we've started the conversation and we're heading in the right direction. So what can you do? I think the first thing is on the acute side. What can you do if you see someone maybe overdosing? I think the tendency is, like maybe if someone drank too much, you might let me just put them in a room and let them sleep it off. Well, when people are overdosing, or especially if they're mixing drugs, as I mentioned, is a dangerous thing. Sleeping it off may be the first sign of them going into what we call respiratory arrest, where they'll stop. So rather than let them sleep it off, those are people that probably need help, and you might be able to save a life by calling 911 for that person. It's good to be aware of at least what potential signs of opiate addiction are. And I'll go through some of them quickly, but things like bloodshot or pinpoint eyes, people who are kind of acting sleepy or sedate or slurred speech, almost like they're drunk, sudden mood changes or major changes in their sleep habits, sudden neglected responsibilities with their jobs, with their families. I think almost anyone who's had a family member who's been addicted to these prescription narcotics would say there was a noticeable change in what their interaction was with their relationships. Maybe they sudden change in friends or hangouts, or legal problems or financial problems, or they start having this drug-seeking behavior where they go from doctor to doctor, hospital to hospital, and they're not open to the thought that, well, maybe you're addicted to the medication. And then be aware that there's withdrawal. If you see things like abdominal pain, vomiting, goosebumps, muscle aches, sweating, those can be signs of withdrawal. And tolerance and withdrawal are both signs of abuse or addiction. So what can we do as family members? Well, I think the first thing is, what's the title of this? Lock your meds. Yes. I think that's got to be probably one of the most important things. I mean, when you think that adolescents can go around feeling comfortable with taking pills, and they might take a few pills, I know we were talking about this off camera, how people would just go into, grandma's house or something, take a couple of her pain medications. She'll never notice a couple of them are gone. Make sure you lock them, and if you don't need them, throw them out. just get rid of them, because addiction is strong. We don't always know who is susceptible to it and who's not, but if they are susceptible to it, don't leave that around as a threat. Support a minimal drug lifestyle. If you can avoid drugs, if you can avoid medications when possible. I know this is funny coming from a doctor to slow down on some of your medications, but as a toxicologist, I kind of hope to end my career in what I call a negative drug balance, where I maybe stop more drugs than I start. And also, if you have a child or someone that is taking medications, controlled substances for prescription reasons, you should probably be the one dispensing it and be in charge of it, so you know what's going on. Accompany them to their doctor's visits so that everything that's going on is true. And if you see signs of addiction, just be open to discussing it. What I feel like has really changed here is it took us to get to an epidemic to where we can comfortably talk about addiction more comfortably. And I know anecdotally, what I have seen is I can now go, and it's very important if you have a friend or family member, not to be judgmental or pejorative when you're talking about abuse or addiction. Addiction is an illness or disease, so rather than turn it to blame, I think if you just open up the discussion and say, look, these are dangerous substances, and if you're coming from a place you actually care about the people you are talking to, you can make a big difference just by having it open. And I've talked to people, I've had people get upset with me, I've had people threaten my life in the emergency room for suggesting that they might have an addiction, but I've also had a lot of people come back and thank me, or at least try to get help. And I have to say the news overall looks good. I mean, 2 years ago, if you were to ask me, I would say there were people coming from all over the country, as that movie Oxy Express will tell you, to come and fill prescriptions everywhere. And I would see our emergency rooms overcrowded with people that I couldn't really pinpoint what what the objective nature of their disease was, but I don't want to undertreat people's pain either. And now with the prescription drug monitoring system, the law enforcement helping, I think with parental awareness, it's just come a long way, and I'm very relieved to see that, but we have a long way to go still.
You had talked about children and taking prescriptions, controlled substances. It sounds like we really need to have some serious discussions with our kids about, yes, you need this, but you need to be responsible with this as well. This is a powerful drug, and you only take it when you need it.
Yeah.
And I think sometimes we don't have those discussions with our kids.
Yeah, I think the discussion helps, and the remembering internally, as responsible as your teen or adolescent may be, if they are susceptible, if they have that genetic predisposition perhaps to be susceptible to addiction, you should maybe be the ones giving them their medication and keeping an eye on it, counting it, and things like that.
My name is Daryl Blanford. I'm a sergeant. I work with the Metropolitan Bureau of Investigations and Narcotics Division. We're going to go through a law enforcement perspective on this, and I think what you're going to find is a lot of my data is going to mirror the doctors. It runs hand in hand. We talk about this as an epidemic. Now, it's a big word. People say it's not really that bad, but until you've got a family member that's shown up that's addicted, you don't realize how bad this can be. It's no different than being addicted to crack. It changes their whole life, and it's growing. Like you said, you saw the numbers there. It's getting bigger and bigger throughout Florida. And towards the end, we are starting to get it under control with certain measures that we're going to go through. But for a while there, we were behind the eight ball. What these are all headlines in newspapers throughout Florida, and you can see all the different ones. If you look closely, you're going to see that a lot of them are from South Florida, and for some reason, it was huge in South Florida for a while. And we had people coming down from Ohio, Kentucky, all the other, some of those middle states were coming and flying into Florida and going down south, filling their prescriptions, then taking them back up north and selling them and using them up there. And South Florida actually was one of the first area that took control of it and started attacking this problem. And as a result, they came north to Central Florida. And now we're in that predicament where we're having to put in some of the same measures that South Florida did. And what's going to happen is once we get control of it, they're going to move to another part of Florida unless we can wrap this whole thing up and stop it, or at least slow it to some degree. At one time, Florida had 90 of the top 100 prescribing physicians dispensing oxycodone. You can imagine that the other 49 states had to share those other 10 top dispensers. And I know that we aren't, Florida is not representing 90% of the pain in the entire country. This is the oxycodone purchases by medical practitioners, which of course they're then going to be redistributed out to the users. And we're up almost at 41 million from January 2010 to June of 2010. And look at your next closest state. If you'll notice, remember I said Ohio and Kentucky? Ohio was number 2 there for pain medication.
Sergeant, is that Do we know why that is? I mean, that's shocking.
I don't know why Ohio and Kentucky seem to be the big problem areas, but they were, every time we would catch somebody or get into an organization, seeing that Ohio and Kentucky, they've even had sheriffs from up there complaining about us not getting control of our pill problem because it was affecting them up north. And there's an affectionate term people like to throw out there. The pillbilly is the term that they use for these people that come out of the Midwest, I mean the middle states, and come into Florida to get their pills and then take them back up north for sale. Hope I didn't offend anybody in Kentucky. And these are some of the examples of your pain advertisements for these clinics there. And you start looking, it was a battle between the different clinics to see who they could get in. It was all about profit. Walk-ins welcome, we'll dispense the drugs on site, $50 for your initial visit, which is well below the standard, $200 to $300 they're normally asking. They're trying to get customers in and build a good base of customers that they can continue to turn money off of month after month. And keep in mind, not all pain management clinics are pill mills. There are people out there that legitimately have pain problems from serious accidents, and they do need these pain clinics, but these pill mills have taken advantage of that and opened up to turn profit.
Do we need better laws? Is that the problem?
Partially, and there are laws that have been enacted that have slowed these down. The bottom line is that we'll never be able to stop somebody from coming in, saying that they're injured and getting that one prescription a month. What we can do is stopping them from doctor shopping and from getting multiple prescriptions. We can make it far less profitable for both the doctors and the patients that are trying to resell it.
I've heard that term a couple of times in doctor shopping. Meaning they go to...
It's just a various way of getting numerous pills. One of the popular ways, the more creative ways, is somebody that has the bank to do it will collect 5 or 6 patients per se. They'll pay for the doctor visits for each one of them. They'll drive them around. They'll get the prescriptions. Then they'll drive them to the pharmacies, drop them at all the pharmacies, and pay for the pharmacies for the pills as well. When they get back in the car, they collect all the pills, give them maybe 30 pills of the 180 for payment. They outlay no money, and he takes the rest of the pills. He goes back. He sells them. The Roxys were going for $10 or $12 a shot, and then he turns a huge profit. You start multiplying the numbers. 180. If he's getting 150 pills of the 180, if you got 10 guys that do that for a month, you start multiplying it out. It's huge money. It's big money for these guys. One of the things they started. I mean, you saw on his charts. 2005, 2010, as things started to escalate. They peaked. 2009, 2010 is where things got the worst. So they did enact some legislation where you were required to register your pain clinic with the Department of Health, and as you can see, there were over 940 pain management clinics, which is insane. There's not that much pain in Florida. Cases filed by the prosecutors for hydrocodone and oxycodone trafficking, 18 in 2005, which is really negligible, 136 in 2009, and we are more than double that now. They've continued to skyrocket. It has become the forefront of drug enforcement. Crack cocaine, it's still there, but it had its heyday, and pills are starting to take over. Road patrol, specialized drug units, gang units, everybody is stumbling into this pill game now, and the arrests are continuing to skyrocket. Next, please. 2010, we were one of 8 states that didn't have any type of drug monitoring program. This is the PDMP that we're talking about, and as you can see from the next slide, where's everybody going to go? All the blue states have a monitoring program in place, so they're going to target the ones that don't, and that's where they're going to go get their pills. Why they didn't go closer? I mean, you can see there's some closer states for Ohio and Kentucky. I really don't know why they came to Florida. Maybe the number of people that we had doing it here was the reason. Maybe just because we had so many clinics. But you can see we were one of the few in this. So it's obviously doable because look at all the other states that are doing it effectively. 2010, over 60 registered pain management clinics in Orange County. I think it was former Mayor Rich Crider that noted that there are about as many pain management clinics in Orange County as are McDonald's. And that's saying a lot because you can't drive anywhere without seeing the LRs. Now we'll talk about the methods of diversion. The friends and family, that was one of your questions there. 70% obtain pain relievers for free, bought or taken, that's 12 and older, throughout the household. And a lot of people don't realize it comes in a number of different ways. Your kids experimenting with them, teenagers taking them to parties. But like I was telling him earlier, a recent example of one of these was early 20s, grandson goes to visit grandma. She's not gonna. She's happy as anything that he's gonna stop by and see her. Brings his girlfriend along, but he wasn't really there to see grandma. He was there to occupy her, while his girlfriend asked, "Grandma, may I use your restroom?" Of course you can. She steps into the restroom and she pilfers the cabinets. And they've all learned this as a technique. They start out with the close family members. Once those are gone, then it's friends. Then it just becomes acquaintances. Let someone in your house, they use your restroom, they open your cabinet, they start digging for the pills. They don't have to take them all. Dump half of them out, put them in your pocket, and walk out. And most people never finish their prescriptions. Very few people get a prescription for oxycodone and use all of them. There's always some pills left in there, and you just never check on them again. So that's one of the primary ways. Doctor shopping, we discussed that. I just go to multiple doctors, get each different doctor to give you a prescription, and then you take it to the pharmacy and you fill multiple prescriptions. And fraudulent scripts and thefts. We have recently, I know the news, I don't know if MBI just had a case on the news where nurses and medical personnel who have access, not the doctors, but some of the staff have access to these pads are just tearing the pads and writing their own prescriptions. So, and there's a number of different ways that you can get a hold of these pills if you really want them. All right, pill mills, we call them pseudo pain clinics. That's another question on there. A high volume of patients. They don't ask a lot of questions. They're purchasing a lot large amounts of oxycodone, and those are all things you can look at on the chart. But if you go into one of these clinics, a true pill mill, as opposed to a pain clinic, all you have to do is open the front doors and step inside, and at 9 o'clock in the morning, there'll be 30 people lined up in there, and I use the term crackhead, but they all look the part. I mean, it's very obvious that those people in there are not all people that got injured at work or motorcycle accidents. They're drug users, and it's obvious to look at and see. And these pill mills have made a fortune on all these people. You can look at the cost. A pharmacy cost of a 30 milligram oxy, which is one of the more sought after drugs on the street, is only $1.42. And like I said earlier, they're selling for $10 to $12 a shot. You get 180 of them, that's quite a profit, $2,000. And then you see the out-of-state value. That's the guys running back up north. You get that same prescription, take it north 3 times for nothing more than airfare to come down. Now we talk about addressing the problem. We realize there's a problem. Obviously, you've seen all the numbers. What are some things that can be done, or have we done? You can see here the Florida was divided into 7 different drug enforcement strike forces throughout the county. They were assigned sheriff and a police chief to monitor those to see how we could combat them in the different regions. And to get more on a more understandable level, some of the things they've done, like in our region for MBI, is they've supplied the funds to go up on a Title III wiretap, where you listen to the phones on organizations. I know you think this is just as 1 or 2 people doctor shopping, but it's grown into where there are large groups, 10, 15, 20 people operating together in groups to get these pills and redistribute them for profit. It's no different than a cocaine organization. It's not common, but they are out there, and that's kind of the groups that MBI targets. So we've used some of the funds from Strike Force and some of their assistance to actually run these T3s, which are quite expensive, and we've taken out several organizations that way. So they've been very helpful, at least in the central region here.
And this is a little bit harder to deal with than, say, an illicit drug that's against the law. You have somebody, they have their name on a prescription bottle.
Exactly.
It's just much harder to crack down on.
There's no prescription for crack cocaine, so if you get caught with crack cocaine, you're going to go to jail on the spot. But you're right, you get caught with a pill, 180 pills in your name on it. There's nothing we can do about it. They say it's for their back and their names on it, they're good. So it is more difficult. You're right. 2011, they brought out some legislation that we talked about, that you mentioned earlier, things we can do to help. Banning the dispensing of the Schedule 2 and Schedule 3 controlled substances. So now the pain clinics, they can still write the prescriptions, but they can't dispense the drug on scene. And that was big, because the guy that's, let's say, shady enough to continue to run these people through and give prescriptions, he's also the guy that's shady enough to give you the pills. And you don't want both jobs in his hands. So they're able to separate those two, which helped a lot. There's some new criminal violations to support the enforcement. And the biggest one was we implemented the prescription drug monitoring program. And you'll hear the term, everyone says PDMP. That's what they're talking about. What that is a database that when you dispense narcotics, you need to have the name of the person you're dispensing to, and you enter it into this database. Law enforcement, if they're doing an active criminal investigation, can access this information and find out who is getting prescriptions, so that if you are doctor shopping, we'll be able to track that down. One of the big things they did was they dropped it from 15 days down to 7 days, is how long they have to actually implement them. Some of the bigger pharmacies, the up and up pharmacies, they'll enter much quicker than that. And this is my personal opinion. That needs to be immediate. And 7 days is too long. They're making huge profits on the drugs. It doesn't take that long. Before you hand the pills across the counter, you enter in the information immediately into the PDMP. They don't get a chance to go to the second pharmacist. 7 days is a long time. I can still drop, scripts at 10 pharmacies and still collect my pills. And people think, well, a regular person would think, well, why would I do that? Because 7 days later, law enforcement's going to see that I did that, and I'm going to get arrested. Well, you got to think of their mindset. They don't think like that. They're not worried about 7 days from now. They're worried about today. Can I get 180 pills today? I'll worry about 7 days, 7 days from now.
Right.
And that's the problem with the PDMP having a delay in their entering. And it wouldn't take that much to do. The PDMP is already in place. You just need the legislation and the enforcement to force these pharmacies to enter right away.
And I would imagine the technology it's there.
It's there.
So there's really no reason.
And the profits are big enough. They're making enough money.
Right.
If you don't want to put the technology in to do that, then don't dispense the oxycodone. It's that simple. These things have worked. Florida now has only 13 of the top 100 prescribed. Remember, we talked earlier, it was 90. We're down to 13, which is huge. I mean, it is taking an effect. Not only do we have fewer prescribing physicians, but you can see, well, the slide's not showing it. It's showing it well. But in the first 5 months of 2011, they're down to 900,000 doses, which is significantly less than you can see the 41 million. I mean, we cut it drastically. So that these pain clinics have gone out of business. It has been more difficult for them to dispense the drugs, and it is taking an effect. And I'll say, we're never going to stop the problem, but we can sure slow it down considerably. And that's what we're starting to see happen now. Remember, we talked earlier, over 60 pain management clinics. We're down to 23. And I believe the majority of those are probably legitimate, but there's still, some of those are still operating outside the parameters, and law enforcement is still targeting them. And we'll continue to try to eliminate the rest of the pill mills, per se. Because oxycodone, it does have that stigma. All the data he showed you on it is the deadliest drug. Everybody wanted to use that one. It's become harder to get, and it's become more expensive. And like we know, most drug users are going to find their drugs one way or another. So now what they've done, they've turned to hydromorphone, which is funny because it's actually far less expensive than oxy. I don't know if you could elaborate on that, the difference between the oxy and a hydromorphone as far as the effects. Are they that much different?
Hydromorphone is thought to be the equivalent of like 10 of morphine. Now, oxycodone, how that fits in is a little bit different. I mean, just my experience, and I don't know that there's any true scientific addiction behind this. I just feel like seems to be, people go to much more extremes, like what we call drug-seeking behavior for the oxycodone than they do for Dilaudid or for Demerol in the past, or Darvocet or some of these other drugs in existence. So,
Yeah, that's what we see too, and that's something I can't explain because.
It's more addictive on the distance. Yeah.
yeah, we were talking about that ahead of time. I'm not sure what drives that exactly, but yeah, certainly.
Just the history of that being the strongest drug they dispensed you when your knee was injured or when they were getting you back, and that became through, the grapevine, that became the drug to get. That was the first big one they gave you. But other things, and hydromorphone, and I can tell you, we find those on traffic stops. The undercover street units are buying it. It's showing up in the gang unit. That's starting to show up more. And our director, Larry Zwig, quoted in the paper, if addicts can't get their oxycodone, they're most likely going to try another drug. And it started with hydromorphone because, again, that is a prescription drug. It's easy to get. But as that's being cracked down upon, they're turning back to another opiate in heroin. And heroin had its heyday here in the early 2000s, but we in the law enforcement in the last year have seen the number of heroin cases increasing. Our investigations on heroin have gone up, and I have to attribute some of that to the fact that we're cracking down on the pill mills and the ability to get the pills. Cities and counties are now enacting ordinances on the new pain management clinics. Obviously, the increase in law enforcement and DEA's prescription take back. Then you can see there getting those prescriptions out of your medicine cabinets if you don't need them anymore, and you're not going to use them. Especially even if you anticipate possibly using them. Everyone keeps the extra oxycodone. Next time I get hurt, I don't have to go pay for that one. I'll keep some in the house. If you live by yourself, maybe, but if you have teenagers or kids in the house, spend the cost of the prescription. Get rid of them now. Pay for them later. And just take that opportunity out of your kids' hands. out of the teenagers' hands. But one of the cleanups you can see there, they took 2,500 pounds of prescription medication. Pills aren't heavy. That's a lot of pills right there. Over nationally, they took 1 million pounds. Orange County Mayor Teresa Jacobs recently created a prescription drug task force to take a kind of a comprehensive approach to the problem. We talked about earlier, it comes from a number of different areas. We have to attack it across the board. It's a 17-member task force to try to provide some kind of comprehensive action plan. And last, one of the effective ones here was in June of 2012, they passed zoning regulations that changed them for pain management clinics. And we had done investigations on them in commercial areas, and we even had them in a residential area. We had the pain management clinics right there in a residential area. Well, the new zoning requirements have put them into industrial areas. So it completely eliminated them from that. You're not going to be able to walk out of your Starbucks and slide into a pain clinic and still work. They're going to move into industrial areas. So these are some of the things that we've done, and there's always more that can be done. And it's a continued fight because they're going to shift to another. Drug users are going to shift to another drug, and we're going to attack that one. They're going to shift here, and we just have to keep after them, keep the pressure on consistently. Thank you.